Hello. If you're facing surgery for gallstones or your gallbladder, this DVD is for you. In it, we're going to describe why it is we're recommending surgery, what the surgery involves, the potential pitfalls and complications, and what your recovery will be like. These are some of the gallstones that I've collected from my patients over the last few weeks. What you'll see is that they range in size from the very small to the really quite substantial. What you'd be interested perhaps to know, though, is that the amount of trouble that patients get is not determined on the number or the size or the shape. And in fact, the patient who had these stones here had almost as much pain, if not more, than the person who had this single stone. So here's a case where size doesn't really matter. About 1 in 4 patients over the age of 70 will develop gallstones, though thankfully not all of them will actually have symptoms. Well, despite the difference, all of the stones arise in the same way. So, here's a quick biology lesson. I'd like you to meet my model, Dave. So, bile is produced by the liver, here shown in brown, and bile passes out of the liver down this duct here. In fact, it goes behind the stomach in pink here, but for the purposes of this demonstration, passes in front and opens out into the intestines just about here. Now, there's a small offshoot coming off from the bile duct that goes into this gallbladder, which is about the size of half a lemon. And when you eat a fatty meal, there's a routine stimulus that causes this gallbladder to squeeze, and the bile comes down its little duct into the bile duct and down into the intestines, where it's ready to digest and absorb the fat that you've just eaten. Bile is a slightly sticky yellowish green fluid, and for some reason, and we don't know why in some people and not in others, little crystals can grow in this pool of sticky fluid within the gallbladder. And over years, these crystals can grow and actually form stones. Now, the problem is, as you remember, when the gallbladder squeezes, what can happen if you've got stones is that those stones can block the outlet of the gallbladder, such that it's squeezing against an obstruction. And that's what causes the acute pain that we call biliary colic. After a patient has had lots of attacks of biliary colic, the gallbladder wall becomes thickened and inflamed, and the whole organ really ceases to work properly. And that's another reason that we need to consider recommending an operation. What else can cause gallbladder trouble? Well, stones in the gallbladder produce pain that's bad enough, but there are other things too. Little polyps can grow in the wall of the gallbladder, and that can cause pain, as can a gallbladder that just doesn't function very well and doesn't squeeze very well. If patients get symptoms that sound like it's coming from their gallbladder and they have these problems, we often recommend a cholecystectomy as well, but I think we can be less confident in these patients that it's actually going to cure the problem. There's also gallbladder cancer, but that really is an extremely rare problem. How are gallstones found? Well, we use the same test that they use for women who are pregnant. It's called an ultrasound. It's totally non-invasive, totally painless, and hopefully the ultrasonographer will be able to find something like this, some stones. Ultrasound is accurate in about 90% of cases. There are a small number of patients where gallstones aren't found the first time, and a second scan needs to be done if the doctor's convinced that there are gallstones, but they're not shown on the first scan. In Jeremy's case here, the gallbladder was clear and no stones were found. What are the treatment options? Patients can and sometimes do decide to live with their gallstones, trying to avoid the foods that would set off an attack, but accepting that every now and then, despite that, they may still get one. We don't push people into surgery, but in truth most do elect to have an operation because at the end of the day they just don't know when the next attack might otherwise come. In the past, doctors have tried shattering stones and dissolving them, and whilst it may have worked reasonably, it left behind the gallbladder, which could then form more stones later. There are some homeopathic remedies which can sometimes be successful in alleviating gallstones, but again the gallbladder is left behind. Surgery is really the only permanent solution. Why remove the whole gallbladder and not just take the stones away? Well, it is easier to remove the whole bag than take the bits out. And if we did leave a little tiny fragment behind, of course, it would then grow into a stone again. Anyway, try removing the pits from a lemon without damaging it. If we really needed a gallbladder to live a normal life, it wouldn't be possible to remove it. But you can live perfectly happily without a gallbladder and eat a normal diet, including fat. Well, that of course begs the question, why do we have a gallbladder in the first place? I don't know. You'd need to ask the manufacturer. But suffice it to say that whilst the gallbladder does have a function, it's a function that we can learn to live quite happily without. When gallstones block the outlet of the gallbladder, that causes enough problem in itself. But when the gallstones go out of the gallbladder on manoeuvres, as we would say, that can cause other problems. A stone can pass out of the gallbladder into the bile duct. Now, if we're lucky, that stone will pass on into the intestine without too much trouble. But as it does so, it can cause some pressure on the tube draining the pancreas here shown in grey. If that does happen, then the pancreas can become inflamed as a result of the pressure of the stone passing through, and this produces a rare condition which can nonetheless be quite serious, called pancreatitis. If the gallstone comes out of the gallbladder, down the bile duct and gets stuck and causes a blockage, then clearly none of the bile produced by the liver can get into the intestines, and that leads to jaundice, yellow jaundice. Welcome to the day surgery unit. This is where you're going to come first of all. You'll meet a receptionist who will sign you in, and then ultimately you'll be checked into one of the rooms like this. There you're going to meet the anaesthetist, you'll meet the surgeon, and you'll sign a consent form. And a consent form is a confusing document, and we want to be absolutely clear with you that if there's anything you don't understand, you must ask. The consent form looks something like this. And on it you'll notice that there are some sections talking about complications. Now this is difficult because at the very time we're trying to instill confidence in you, we're also going to be having to mention the things that could go wrong. But you need to understand that our interest is in making sure that you really understand both that you're having an operation and the things that might possibly go wrong with it. We won't mention everything, but we will mention the common things. So when you arrive in the ward, you'll be shown to somewhere like this. This is a single room. There may be a bay with 4 beds in it. And this is where the nurse will come and check all your details. We'll go over everything with you before going off to surgery. It's also the same room where the anaesthetist will come and visit you and the surgeon to sign the consent form. We need to just warn you, there are going to be lots of times when you're going to be asked the same questions. But bear with us, this is just part of our checking process to ensure everything is as safe as it possibly can be. So this is the anaesthetic room, and you'll walk through into this and lie down on the trolley. In this room will be the anaesthetist, an anaesthetic assistant, and maybe 1 or 2 other people. We'll go over some other checks, again the same ones as before, just for security's sake, and then you'll be put to sleep by the anaesthetist, and then we'll go through these doors here into the operating theatre itself. The next stage is the operating theatre, where the operation will actually be done. Of course, you'll be asleep at this point, but I'm very grateful to Margaret, who's a patient of mine who had this operation done a few weeks ago, who's come along to help us today. Now, before 1990, we used to do this operation through at least a 6-8 inch scar across the top of the tummy here. And the trouble with that was that whilst it was a good operation, it meant the patient was in hospital for nearly a week and would take probably 6 weeks to get over it. Nowadays, with keyhole surgery, using the sort of stack that you can see behind me, it's possible to do the same operation, exactly the same operation, but through 4 little holes, as you can see on Margaret's tummy here. 1 below the belly, and 3 in a little line underneath the right ribs here. We can do this because of keyhole surgery. Keyhole surgery is done using a camera like this attached to a long telescope, and that's what the surgeon looks at the image of on the screen here behind me. The whole operation can take anything from 30 minutes to 2 hours, depending on the difficulty that the surgeon encounters. You need to know that in about 2 to 5% of cases, the surgeon won't be able to complete the surgery laparoscopically and have to make an old-fashioned cut. But in 95% of cases, you'll be going back to the ward where you came, and the nurses will be preparing you for going home. They'll start you drinking, then ultimately eating. They'll make sure you're comfortable and have got painkillers, and they'll give you instructions about the dressings. There won't be any sutures to remove. And so, hopefully, after a few hours, you'll be prepared to go home. What sort of things can go wrong? Well, clearly we can't mention every single possible thing that could go wrong, because some of them are really very rare. But I do want to touch on 1 or 2 things that might, and please remember that if there's anything else you want to ask, you're free to do so. So, the common things that could happen. Bleeding. Significant bleeding after a laparoscopic cholecystectomy is really very uncommon. It might possibly need another operation to stop it, but that is very unusual. If the surgeon thinks there's a little bit more bleeding than normal, what he may do is put a little plastic tube inside the body coming out through one of the holes in the skin, and that tube, once it's done its work, will be removed after a few hours. A little bit of minor bleeding from the wound itself is quite common and usually just managed by changing the dressing and bathing the wound. Infection is a risk of almost every operation. We will give you an antibiotic before the operation starts, and the worst that you'll probably get is perhaps a little bit of tackiness around the bottom of the tummy button wound. That can simply be managed with bathing and dressings. Conversion to an old-fashioned open operation. In about 2 to 5% of cases, it won't be possible for the surgeon to complete the operation laparoscopically, and he'll have to convert to an old-fashioned open operation. That's because the fingers of his hand are a lot more flexible than the rigid instruments that he's using at keyhole surgery. Another reason for conversion might be, for instance, if there's any excess bleeding. Bile duct stones. Stones or fragments of stones that have passed out of the gallbladder into the bile duct will of course need to be dealt with before your treatment is complete. Now sometimes surgeons will suspect that there are bile duct stones on the basis of the fact you've been jaundiced or your blood tests are abnormal, and in those circumstances he or she will probably do an X-ray during the operation to prove or disprove it. Sometimes, however, it's possible that the bile duct stones won't reveal themselves until some time after the operation is done, and that might be on the basis that you don't get better in the way that they're expecting you to. But we deal with bile duct stones with a procedure, a separate procedure called an ERCP, and I'll talk about this later on. Leakage of bile. It's very rare, but sometimes there's a little leak of bile from the bed of the liver where the gallbladder was. And if that does happen, it's occasionally necessary for the surgeon to do another little keyhole operation to put a drain in to take it away. But it's very rare. Inadvertent damage to other structures. It's incredibly rare, but sometimes important structures like the bile duct can get damaged at laparoscopic surgery. We need to mention it, but I do want to reassure you that that kind of incident is extremely rare.